Hello, everybody. I'm Commissioner Marion Green for District, and I represent District 3, and I'm the Vice Chair of the Hennepin Healthcare System Board. We've just been meeting as a board, and we're now transitioning to the 2025 annual meeting, and I want to welcome those of us who have joined us in person and people who are on the phone as well, attending virtually. First, I have some housekeeping. If you have any questions as we go along and you're attending virtually, please put them in the Q&A. They will be seen and responded to and gathered in that way. If we don't get to all the questions, we will be posting a recording of this meeting online with a summary of questions and comments that we receive, and you'll find that at hennepinhealthcare.org/annual meeting. We're going to start our meeting this year with a video look that's a year in review, which we're all looking forward to. That's going to be followed by an update on our progress at implementing the community health needs assessment. Then we're going to hear from 3 Hennepin healthcare leaders about the safety net Hennepin healthcare provides for the state of Minnesota. The ways in which Hennepin Healthcare responds to our community in moments of trauma, the ways that Hennepin Healthcare advances the response to the opioid crisis, and the ways that Hennepin Healthcare trains the next generation of healthcare providers. And those are 3 highlights, but as we all know, there are numerous ways that Hennepin Healthcare is providing for the state of Minnesota and the region. Just this weekend, I think there was a newspaper article about somebody being flown in from Wisconsin. So then we'll hear from the mother of a young Hennepin Healthcare Burn Center patient talking about compassionate and quality care that her daughter received at Hennepin Healthcare. And finally, we're going to look at what's ahead for Hennepin Healthcare, and then we'll go to Q&A. So thank you for allowing time for that overview, and now please roll the tape. Thank you. As I mentioned, this annual meeting is an extension of our regularly scheduled meeting of the Hennepin Healthcare Board. And so I think it makes sense now to introduce the board and just note that our board is made up of the Hennepin County Board of Commissioners. So why don't we start to my far left here?
Debbie Gotel, Hennepin County District 5.
Kevin Anderson, District 7.
Marion Green, District 3, which is a chunk of Minneapolis and St. Louis Park.
Irene Fernando, District 2.
Angela Conley, District 4, home to HCMC.
Heather Adelson, District 6.
And Commissioner Lundy from District 1 had a conflict today, but I know his heart is with us. The Hennepin Healthcare System is a subsidiary corporation of Hennepin County, and this year the county commissioners assumed the role of serving as the Hennepin Healthcare Board. Our board members are, as described, the county board is also the HHS board. And we are all moved by the mission of this organization and come to this work with a lot of passion to learn and understand it better and serve the organization to the best way possible. And now I will segue into the next item on our agenda. Thank you, Dr. Clement, our CEO.
Challenging year with challenging years ahead, but rolling up your sleeves and getting involved and helping us keep this very special place open. So thank you for that. I also want to thank my executive team, Abdirahman Abdi, Lisa Anderson, Rachel Danette, Eric Ling, Wendy Stulak-Motzel, Nneka Cedarstrom, and Megan Walsh for also being all in on helping this place to thrive and survive in very difficult times. Your strong commitment, all of our strong commitment makes this thing work. So I am grateful for everybody who's involved in that work. For today, our theme is safety net care for the state of Minnesota. It's been an incredibly difficult year with difficult years ahead. It forces us to examine who we are and why we matter. And so you're going to see just a few of the aspects by which we help not just Hennepin County, but the entire state of Minnesota. This is a place that is dear to nearly anyone who's had experiences there, has received care there, has noticed the incredible mission that we have. So a couple of statistics: 4 out of 10 trauma patients, we're excellent, outstanding, world-class level 1 trauma centers, but 4 out of 10 patients come from outside Hennepin County to that. Over half the doctors in Minnesota practicing today have spent time in training at Hennepin Healthcare. We have the only hyperbaric chamber in the region. We have outstanding and robust mental health support, the only inpatient psychiatric unit, or the largest one in the state, with ECHO and other programs that help all Minnesotans suffering with mental illness to receive care and support. Poison control, toxicology, blood bank, the list goes on and on. You're going to hear about a few of them today. So I'm pleased to give you at least a snapshot of the things we do, but it comes from a place of really hard shared work and a shared commitment to the mission of this place. So with that, I'm going to hand off to Amy Harris, who's going to give you some update on the community health needs assessment, which is how we listen and interface with our community and make sure that the care we provide is the care that our community wants and needs. So Amy, you can have the floor.
Thank you, Dr. Clement. So I'm Amy Harris, I'm the Population Health Director, and I'm standing in today for my colleague Laura Bowen, who worked through 2025 with a lot of partners and colleagues to be able to produce our 2025 Community Health Needs Assessment and Implementation Plan. This is something we go through every 3 years as a nonprofit hospital. The assessment allows us to be able to identify the most important health needs to our community, and the implementation plan is what's used to structure over 3 years actions we can take together to try to make a difference against those needs. So the theme throughout all of this work is really partnership. We did the assessment in partnership with many colleagues, some of whom are here today and online, representatives from Hennepin County and from community agencies, as well as leaders and clinicians from within Hennepin Healthcare. The needs that we identified, which I'll share with you in a minute, are big and systemic. And the way in which we address those needs is by working together across the sectors. We could not do it alone. Clinical care is good at Hennepin Healthcare. County is able to leverage policy and financing. Community organizations have cultural relevance and trust and deep relationships. And the strength of our plan is really by bringing those things together. So I'm just going to share with you briefly the 3 priority needs that were identified in 2025 and a highlight of some of the actions that we intend to take over the next 3 years. So one of the needs that was identified was community-centered prevention and health promotion. Across our partners, prevention emerged as a shared priority, and it became evident in the data that we needed to work upstream in partnered ways around prevention. We know that prevention works best when it's culturally attuned and designed with community leadership, and this means honoring cultural practices, language, and community-defined measures of health. So within this need, there's actually going to be 2 focuses in the prevention and health promotion category. We'll be working on heart health prevention and food security action. So for heart health, we're going to aim for culturally tailored programs that support heart health, including community wellness activities, increased screening, looking at healthy heart behaviors in culturally tailored ways. Addressing food insecurity means expanding access to resources and nutritious food within our patients and communities and families. Measurement in this work will look at program reach and impact, as well as partner trust and satisfaction. Another need that we identified through this process was mental health and substance use disorder. The data showed us that these are urgent issues across our county and our community, and it really cuts across every system and everyone that's represented here in this room and in this work. What we've heard consistently is that mental health care must be culturally responsive, trauma-informed and accessible, and that clinical care must also be complemented by culturally grounded traditions and trusted community spaces. And again, this is where working together with our partners will really be able to make this work come to life. And so within this broader category of mental health and substance use disorder, the implementation plan is going to focus on strengthening coordination across systems and expanding culturally relevant supports. A couple examples of that, we'll focus on growing partnerships with culturally specific providers and organizations. We're going to build better referral and care coordination pathways, and really try to honor spiritual, community, and culturally tailored goals by including them in our patient care plans. Another priority need is the perinatal and child health category. This is one that is deeply important to partners and also one where we see deeply inequitable outcomes, as evidenced through data we studied through the assessment process. Families tell us that they want culturally respectful, relationship-centered care. They want services like doulas that can understand their language and tradition, and they want the support systems that work with families to align and not contradict one another. Again, we can't do this alone. We must do this across partnered entities. So the focus in this area will be around strengthening culturally specific perinatal education and birth support programs, streamlining early childhood referral pathways, and building models that can reduce the burden for parents and empower parents. And measurement in this area will focus on engagement in programming, as well as prenatal and postnatal care outcomes. So I want to thank all the partners who were involved in this process, our internal clinicians and care teams, folks that helped pull data, community partners, many, many county partners. This work reflects input from a variety of stakeholders. We are just in the final phases of moving through the approval process with this. The website that's listed here is the page on our website that houses information from previous community health needs assessment. And we think the new plan should be posted to there next week if you're interested in learning more. Thank you very much.
Thank you, Amy. That's amazing work. Next, I'd like to introduce our Emergency Preparedness Manager, Seth Jones, to talk about how we respond to our community in moments of trauma and significant emergencies. From around the state, we are a hub, we are a center, as Seth will outline for you guys in this space. So come on up, Seth.
Thank you, Dr. Clement. Thanks, everybody, for having me here. As you mentioned, my name is Seth Jones. I'm the Emergency Preparedness Program Manager at Hennepin Healthcare. I also manage the Hospital Preparedness Program, which is a federal grant program for the 7-county metro region to ensure that hospitals, not only hospitals, but EMS, local public health, local emergency management are able to be prepared, respond, and recover from disasters. Next slide, please. First, I want to cover a couple of recent events in some of our current focus areas. Obviously, mass casualty shootings have been on the rise or have happened here in the metro. On August 26th, we received 7 gunshot wound victims from an incident. The very following day was the Annunciation shooting, which is, I know, heavy on everybody's hearts and minds. That day we received 10 victims from that incident, 8 of those being pediatric, 5 needing immediate operating room procedures, life-saving care. We continue to look at infectious disease. Measles continues to make its way to the media. We did recently have a potential Lassa fever. Thankfully, it was a rule-out case. Lassa fever is in the same category and is considered a high consequence infectious disease similar to Ebola. Family support and reunification following the Annunciation shooting. We're working on that in 2026. We also, just a couple weeks ago, had a exercise, a mass casualty carbon monoxide exercise, where we surged our very special hyperbaric unit that Dr. Clement alluded to. Continue to update our pediatric mass casualty updates or our plans from previous incidences. And then living in the age of technology, we oftentimes have downtime, outage planning. So how do we ensure care and continue to do the amazing work we do when our systems are down? Is a look at in 2026 as well. Next slide. Here's a photo of our hyperbaric unit. This is the surge exercise we had. We had upwards of 20 mock victims surge our area. And as Dr. Clement mentioned, this is the only one in the region that provides this type of care. Thanks. Next, I want to talk about our role, not only locally, regionally, but at a statewide level. HCMC is the home of the Regional Healthcare Resource Center, or RHRC. Whenever there's an incident in the community, whether it's HCMC or any of our 26 hospitals in the metro, 150 skilled nursing facilities, literally thousands of clinics, home care, hospice, assisted living centers, that RHRC will stand up and help support that event. HCMC is looked to be preparedness best practices around hazmat, infectious disease, burn surge, and of course, trauma incidents as well. We continue to advocate for the Healthcare Coalition and statewide bed coordination activities that continue to come up across the state. Some challenges and risks that we've been facing, as well as going into 2026. Most of you are familiar that there's a shrinking healthcare capacity statewide, especially in rural areas. That HPP funding, which supports the Healthcare Coalitions, supports that RHRC that I spoke to, is likely to cease in 2026. We are looking at we have a high risk for severe flu season coming up. Every Thursday, MDH puts out new data, so we'll be anxious to see what that looks like today, as trends are likely to start increasing there. The complexity of the threat environment, from daily incidents, staffing shortages, to IT outages, to larger disasters, man-made, technological, et cetera. I mentioned disease, and then defense, not just our critical infrastructure, but also our cybersecurity defense is important as well. We've got a very complex integrated systems. It's very good to be integrated. However, if one of those systems were to go down, there could be a cascading event that could impact multiple other systems. So just understanding the complexity there, having redundancy, and again, back to those downtime procedures. And then the last piece, education and training needs. Healthcare does have a high turnover rate. We are seeing early retirements from our most skilled professionals. So just making sure that not only at the bedside, these folks can provide the amazing care that they do, but then also if we are stretched and if we do have an emergency, trauma, some type of surge, our folks are able to respond to that to the best of their abilities. So those are some of the challenges and risks ahead of us. Again, thank you for your time. Looking forward to the Q&A session. Thanks.
Thank you, Seth. That team really shined, I think, throughout COVID and with Annunciation in particular. So thank you for your work. Next, I'd like to introduce Lauren Graber, who will be speaking about a program that advances our response to the opioid crisis in pregnant people. Dr. Graber is board certified in family medicine and addiction medicine, caring for patients in the hospital and clinic with interest in pregnancy, parents of younger children, and adolescents. Welcome, Lauren.
Hello, I'm Lauren Graber, and it's easy to talk about the thing that you care a ton about. So thank you for hearing me out. I'm excited to talk to you about our Flourish program, which is a program for pregnant and parenting people with substance use disorders. But I do think it's helpful to kind of think a little bit about the context here in Minnesota in particular. You know, we are really concerned about the number of overdoses that we see both in our county and across our state. It is horrific on the floors every day. This does mean a third of our hospitalized patients have a substance use disorder. And of course, what's in the news is how many people are dying from it. The number of people who survive is another story. And what's even more concerning is the number of individuals that those people affect. The ripple effect of families and children who are in this moment it's very concerning. And as this Star Tribune article shows, the work we're doing as a state is insufficient to support families affected by substance use. As it went forward to say, parents' drug abuse is the top reason Minnesota children are removed from their homes. Pregnancy and birth can be key moments for intervention, but a patchwork of approaches means many families fall through the cracks. It is important to know that one of the leading causes of maternal mortality is substance use disorder in the state of Minnesota. We as a state desperately need to do something different. You know, and I think about, so what do we do? The medicines to treat opioid use disorder are by far the most effective ways to reduce overdose and reduce the risks associated with substance use and create and support functional families. Here in Minnesota, we have about 20% of our Medicaid enrollees who are pregnant get that medication care through their pregnancy. 65% who give birth and in the year after receive none of these medicine evidence-based interventions to help them kick this horrible medical illness. And after that little baby is born, these rates don't get better. In fact, we find that as that baby ages from 1 month to 2 months to 3 months, people are taking less and less of those medications that help create and support their stability. So working at this hospital, this safety net system allows us to really think about things differently. We have, since 2020, hosted a provider education series called ECHO that is for the entire state. I currently co-direct the perinatal substance use ECHO. And this where we're really training and supporting providers across the state to know how to use those medicines and help increase access and to work on the stigma and support so that people can come forward, access care, have healthier pregnancies, and have healthier families. That's the big way that HHS is supporting and how we're intervening in this state. The smaller way, which I find is really innovative, is this model for trauma-informed care, really building on the advocacy and the expertise of our addiction medicine team, our women's health OBGYN teams, and our pediatrics team, and our state's only perinatal psychiatry program, the Red Leaf Center for Family Healing. Those groups coming together to create this program called Flourish. So this is a program that is designed and focused around the pregnant and parenting person and child and offering them a menu of supports to help them heal through their substance use and be the parent that they want to be. This is grounded in community-based research, and we have a very active community-based community advisory board that's keeping us accountable and also making sure that this program is doing what our community needs it to do. We are 100% at this moment supported by the philanthropic efforts of the Hennepin Healthcare Foundation. And I really want to name that because this type of innovation, where you're breaking through silos and providing additional stuff, this isn't what traditional healthcare models are reimbursing for. And so it's with that great support that we've been able to develop something different and are in great intention that as we hold up these different roles, that we're going to be able to spread and utilize these models across this state already with those many connections that we've built with providers. I want to highlight two parts of this of our model. This is a model where we are bringing an addiction provider in and working with a mental health provider to deeply consider, how do you be a parent in recovery? How do we sustain this? This is the long game. It's not just those 9 months of pregnancy. You parent for so many more years after that. So this is really setting folks up for all of that support. And I'm really proud to host Minnesota's first peer recovery doula. This is a person with lived substance use experience and birth doula experience, and they will walk this path with our patients to support them in that most vulnerable time. We're really excited about this. We have to do something different. This program's really allowing us to start to pioneer that, and it's very embedded within our larger community in terms of what people are looking for. You know, I do this work because I believe in it. I know that people who've used drugs can be fabulous parents. I know that people need the support to get through that and to be in a place where they can access without stigma and without that judgment. I am proud every day to work at Hennepin Healthcare and how we are modeling that and how we can spread that bit of wisdom across the state. So thank you so much.
Thank you, Lauren, for the amazing work. Appreciate that. So as a former medical student about 27 years ago at Hennepin and a more recent geriatric fellowship grad, I'm proud to introduce Dr. Megan Walsh, our Chief Academic Officer and President of the medical staff, to talk about our mission in education and training at a statewide impact.
Hello, everyone. Megan Walsh. I'm the Chief Academic Officer at Hennepin and an internal medicine physician. And I'm here to talk about how Hennepin trains the future healthcare providers, specifically physicians for the state of Minnesota. Next slide. So our safety net mission is one as a teaching institution. We have been in this business since the late 1800s. 1890 was our first learner, and we continue today. At any given moment when you go into Hennepin, there are over 300 unique physician trainees, residents, and fellows, as well as an additional 100 medical students spanning 60 specialties, both learning and contributing at Hennepin Healthcare. So why go to a teaching hospital? What's unique? What is the business case? The business case is that we recruit the most diverse trainees from all over the world who come to the hospital and bring their culture, their insight, their uniqueness to the care we provide for all. We are a diverse physician practice group and trainee model, and that builds inclusivity that we wouldn't have otherwise. We are the largest safety net teaching hospital in Minnesota. And our trainees rotate at Hennepin and throughout our partners in the metro. Every major hospital, we both train their residents and we send our residents to them. But we also have branched even further. Next slide. We train our physicians to care for patients facing homelessness, addiction, trauma, mental illness, and linguistic cultural barriers. We are unique compared to other teaching hospitals for the breadth of experience and truly the mission-driven orientation that our trainees choose to receive at Hennepin. They also receive high reliable care, health equity training, education, and community engagement that they then bring statewide. Next slide. About 2 years ago, we recognized that the majority of our training was in the metro, and we were seeing both trainees who wanted rural training experiences as well as our rural communities are in desperate need of a physician workforce. In the northern third of Minnesota, there are 2 child and adolescent psychiatrists. The OB footprint is diminishing rapidly. The ability to recruit physicians with expertise across a wide array of skills is in desperate straits, and we need to contribute to solve that problem. So we partnered with Sanford Bemidji Hospital for a few reasons. They have the 3rd largest Medicaid population served in the northern third of Minnesota. They brought resources, faculty, and a committed interest to teaching. And we partnered in addition with MDH, Minnesota Department of Health, who helped fund a startup grant so that we could send residents to Sanford Bemidji. Where are we now? We send emergency medicine residents. Every single one spends a month in Sanford Bemidji. They also work with the tribal communities in that region. We have now expanded to psychiatry residents, child and adolescent psychiatry interested residents who perhaps may want to stay in those communities when they complete training. We've added internal medicine. We're going to be adding family medicine with obstetric interests to these rural communities. And this is Hennepin's goal, is to truly be a provider of a workforce for the state broadly. Next slide. We also recruit to diversity, and we want to build a model that our trainees reflect the patients we serve. I honed in on one particular strategy in our emergency medicine program, which was expanding Native American representation in Minnesota's workforce. On the lower left corner, 2 of our Indigenous residents who chose Hennepin from Washington State because they believed in the mission of who we serve, the communities they work in. They were really interested in the Sanford Bemidji program and the tribal communities there, and they have mentors, as Dr. Cedarstrom says, If you can see it, you can be it. We have Native American physicians, the largest number in emergency medicine in the country, who are actively building a cultural reflection to best provide care to our local communities. Those who go to Sanford, regardless of where they hail from, when they train in Bemidji, they walk away saying, I better understand the uniqueness of culturally reflective care. Next slide. State workforce planning, most physicians will choose to practice within 100 miles of where they train. So we need to train them outside of the metro. Nearly half of our graduates who return to Minnesota choose rural communities to practice. We have a rural workforce shortage in this state in primary care psychiatry and surgery, and we all have a role to play to solve for that. GME, graduate education, is the pipeline solution. Each residency slot is a long-term investment in the statewide resource and of the workforce. And Hennepin's diverse patient population produces clinicians skilled in complex care, skills urgently needed in rural hospitals. Next slide. Thank you. This is our surgery graduate group who is heading to Bemidji in a month.
Thank you, Megan. Appreciate that. Lastly, I'd like to introduce you to an aspiring gymnast, an overall bouncing, active 70-year-old Sage Starr from Nowthen, Minnesota. Sage was enjoying a weekend at her family's cabin in northern Minnesota on June 7th when she accidentally tripped and fell into a fire pit. The flames were out, but the coals were still very hot. Her grandma, a nurse, acted quickly to help, but Sage suffered burns to her left arm and was brought to HCMC's burn unit for care. Here's what Sage and her mom, Jamie, have to say.
She wanted to go outside. She just had her pajamas put on. So she went outside, and we never thought anything like this could happen, but she wasn't doing anything wrong. She was just standing there eating her cupcake, kicking the mulch, and she lost her balance. And one hand went on the brick, and the other hand went in the fire, and she caught herself. So it just can happen so quickly. We were at a Christian concert in St. Paul. We were on our way back. My phone had just died. So it was being charged in the car. And I got the phone call from her dad saying that she had fallen into the fire and that an ambulance was on the way. So right then I knew that it had been very serious, and immediately, I called my sister, and we just had people starting to pray for her. And it was just kind of a God thing of how it all came full circle of like my day being down here at a Christian concert. My heart was in the right spot to receive news like this. And then their dad and grandma and everybody, we just came together as a team. And I'm just so thankful that we have a hospital so close to our house that gave us the expertise and the care that I think truly made a huge difference in where she is now. You would never guess that this happened, from the physical therapy to the emotional side of things. She had a child life specialist. We had the art teacher, and we had music, and they just made it seem so comfortable for a child in a burn unit. Honestly, I think the whole staff, from the doctors, the nurses, people in the cafeteria, everybody in the hospital, they made it so magical. From the times of going through the hallways on the tricycle, I thought she was going to get into trouble. And everybody had the biggest smiles, seeing her cruise, rounding those corners, almost taking people out. And people were just smiling, seeing that she's having a good time. She was actually really excited to see some of the doctors and nurses from before. She was very eager to get cleared to go swimming because it happened in the summer. Very sweet. Very sweet. Everybody was so kind. And everybody was just so warm and welcoming, and we can't thank you guys enough. And we're just so thankful that God really blessed us.
It's good to stop and remember what it's all about, isn't it? I'll keep my closing remarks brief and try to allow some time for Q&A. I love this place. Obviously, you've seen a number of people who also love it. And I also feel the shared commitment in this room. The challenges that we face going forward are monumental. The folks that we care for that we don't get reimbursed for is growing. It is going to grow further if current federal legislation persists. So it's going to get harder, not easier. It's always been hard. But healthcare is also broken, and that's more than just sort of empty words. America spends the most per capita on healthcare of any country on earth. I believe it might be double the second. We are 40th in life expectancy. The healthcare is fragmented, it's dehumanizing, and it often perpetuates racism. So it is time for a change. It's very scary to think about that change, but there's also opportunity. I think I know two things. I know that people are still going to need help going forward, and I know that together we can face that challenge as we have and as we will continue to. So I'm scared, but I'm optimistic. I tell my team to trust the mission. It's the 1,000 things we do every day at the hospital and at the clinics that make us worth preserving and worth fighting for as we are. So I implore my team, do your 20 really well. So I think we need to believe in that, and I have confidence in this team. I'm scared and nervous about the future, but I believe we can do this together. So I'm going to end my remarks there. Commissioner, if you have anything to add, we can open up for Q&A.
Those were fantastic closing remarks, and thank you for your commitment and passion. Why don't we open up to Q&A?
Hey, everyone. Hey, commissioners. My name is Abdurrahman Wako. I'm the executive director for Elliott Park Neighborhood Incorporated. And I would like to know if Hennepin County is still planning on building the ramp in our neighborhood.
And let the commissioners answer. It's been delayed. I know that. So
I think the answer is that it's under consideration or reconsideration.
Okay.
Thank you.
we appreciate your partnership too. Appreciate everyone for attending and the work that you do. So
Yes, thank you, and I will call us adjourned.